Okay, so I would like to welcome everyone to session 2C, Advancing Maternal and Reproductive Health in Rural and Northern Communities. We really value your presence here. And just a kind reminder for everyone to please mute your microphones and turn off your cameras, except for the presenters. We have 3 wonderful presentations. Each presenter will have 15 minutes, followed by a 5-minute Q&A. And closer to the time, I will share time cards for presenters to show how much time is left. So please open up the chat box so you can monitor and see the time cards. And with that, I would love to introduce our first presenter, Lee Yates. And the floor is yours if you would like to share your screens. I'm just going to stop sharing now.
Amazing. And I am going to be co-presenting alongside Lee as well. Okay. Am I sharing the right screen with you? Does that look like the presenter screen? Yeah? Okay. Amazing. Well, really nice to be here. My name is Anne, and I'm going to be here alongside Lee and sharing some of our work on supporting rural and remote maternity care through enhanced MABEL services. Both Lee and I are speaking today on the traditional and unceded and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh people. We're both based in Vancouver, and where we're calling in today from and the communities that we have served and work in partnership with daily are located on the lands and waters which have been stewarded by Indigenous people since time immemorial. Before we begin, we also just want to acknowledge that all members of our team do receive compensation for their time through the LHS grant and MABEL service. And if it's okay, I'm going to just note, I think someone is off mute. If you wouldn't mind just muting your microphone.
Yes, I will mute everyone right now. So thank you for the heads up.
Thank you. So systemic and geographic barriers impact the availability and stability of care at the remote edges of BC's healthcare system. These edges are often a legacy of the larger colonial process that has created ongoing inequities in access to care and related health outcomes. This lack of service often results in patients having to travel long distances or, in some cases, foregoing care altogether. For generalists serving these communities, the isolation can make it really difficult to help patients with unfamiliar presentations, leading to feelings of moral distress and impairing retention and recruitment. In spite of these systematic barriers, we actively challenge the idea that the edge is merely a place of marginalization. The unique setting and context of rural, remote, and Indigenous communities position them as centers of creativity and innovation and where deep partnerships can be fostered. The Real-Time Virtual Support Program, RTVS, was developed to support these edge communities. It's a suite of interconnected clinical pathways linking rural and remote healthcare providers, so physicians, nurses, midwives, with physicians for timely peer-to-peer support. RTVS is built on a culture of compassion and a mindset of how can I help? So emphasizing kindness, delivering culturally sensitive and trauma-informed care that really recognizes both the historical and current factors impacting health outcomes in the community. Care is provided by providers who understand the unique challenges of delivering care in remote communities and wrap their clinical expertise around isolated rural providers, creating opportunities for joint decision-making that previously didn't exist. MABEL, the Maternity and Babies Advice Line, was designed to bridge maternity care gaps specifically. MABEL contributes to improving quality care and safety for birthing people and newborns, offering timely support across the spectrum of preconception, prenatal, intrapartum, and postpartum care in both urgent and non-urgent situations. MABEL can also help with other sexual and reproductive health issues. And the team of physicians and midwives are accessible over phone and Zoom. Dr. Amy Sawchuk and midwife Lee Yates both have a deep understanding of the existing barriers to accessing comprehensive perinatal care in the province, learned both through their clinical work and leadership in Maple. They applied for a grant in 2022 with the main goal of understanding if there was an opportunity to enhance perinatal care in rural and remote communities through the platform of Maple. To begin, the project team really leaned into their relationship with close partners, colleagues, and care providers, working together to identify communities that may be interested in partnering. Relational work was really central to initiating this project. The team really intentionally built upon longstanding relationships established through the RTVS program, and partners offered their connection with communities as a relational bridge for our team. The project team really wanted to try and approach this work differently. We tried to embody and center the core values of relationality, trust, consistency, and reflexivity in envisioning and carrying out this work. Throughout the project, it did challenge many of our deeply held assumptions and motivations, including those to move more quickly than perhaps there was readiness for, and taking a more action-oriented approach that is typical in project implementation. It required openness to discuss and explore our motivations as a team, and relying on each other's commitments to these values to embrace waiting periods. There was learning across the project and continues into the work today in the time and intention that it takes to work relationally. Embracing the waiting periods between communication, it took the project team around 6 months to identify and approach one community to partner with. In August 2023, the team was invited to visit the community of Quadacha, which is located in northern central BC. And in October, the project team, so Lee, Amy, myself, and one other staff, traveled to Quadacha for a site visit. And the question that guided the visit was, what would enhance prenatal and postnatal care in your community? Over the 3-day visit, Indigenous life givers, elders, family members, healthcare providers, and health administrators shared their experiences in multiple learning circles and conversations, sharing their knowledge and experience around what local perinatal care looks like. What was learned spanned multiple aspects of the perinatal care experience, such as prenatal appointments, educational needs, support systems within the community, and traveling and staying in Prince George to deliver.
Thanks, Anne. Hi, everybody. Grateful to be here. Thank you for the invite to share our work. Picking up from where Anne left off, as we consolidated what we learned from and with the community, we looked to what work can Maple support, or what supports can Maple provide, and connected with other healthcare providers and health partners to start to build pathways to some of the other needs and work. And so our work focused on enhancing perinatal care within the community by supporting the local providers. And this expanded from Quadacha to include Seke Dene, as the communities are closely linked and often share providers between communities, in particular their primary care providers. And so we co-developed a supported chart review process. Those chart reviews occur monthly, so we meet regularly on the first Thursday of every month. It's an open invitation to the care providers in each community. It's peer-to-peer support. Always myself or Dr. Amy Sawchuk. And we set up the meetings to work within the existing clinical workflows and relationships within the community. So really focusing on the needs of the local teams and embracing that how can we help, how can we best support you approach. The chart reviews are small group structures that allow dedicated time for discussion and help support the relationship and increase comfort in asking and answering questions. it's co-knowledge sharing, learning, and mentorship space that starts with what the providers already know and brings curiosity and interest-based questions into that. Importantly is the assurance of privacy and consent. And so before we talk about any of the patient charts or the Indigenous life givers, the team on the local, in the local communities has connected with the patients, the clients, to ensure that they've provided, they're informed about what's happening and they've provided consent for our inclusion in their circle of care. The chart reviews enable, in particular, the remote RNs, who are often a workforce with a very high turnover, to enhance their perinatal care knowledge and experience, and recognizing kind of the ripple effect that even in a single encounter, it builds their knowledge that and increases capacity that can then be carried to other communities and other sites as they are rotating through their contracts. The enhanced access to perinatal education for them and enhanced community of care for community members is enabled through the chart review, and it alleviates the burden. So the consultative side of it alleviates the burden of traveling as frequently for perinatal care when we're able to, for some of the concerns or conditions that arise. In terms of impact on patient care, I want to just read out the quotes instead of trying to voice over them. So one of the nurses said, because the clinical care was taken care of, the rest of my time, I could give the patient extra time and support, her mental wellness, and all the barriers that she's facing. So the outcome for that client was that she completed all of her prenatal visits and way more. Another nurse said, to have access to expert consult and opinion on a preventative basis. Usually we're reaching out to experts when things are going sideways and we're trying to piece together some sort of care plan. And the impact for providers, again, in their words, the way the chart review is done saves time for us and has a good positive output on much more comprehensive prenatal care. And that's really valuable because most of the things that we do to improve patient care add more time. And so I'm really thankful for that. And the sense of relief that I feel just going into it, because I generally feel anxious seeing any prenatal visit. I worry that I'm going to miss or forget something that is just because of what I don't know. So having someone who's much more experienced going through it and writing a plan has allowed me to just be more present with the patient in the visit. I definitely think I'm providing better care overall because of that. So highlights from the work that we're doing. We're now a year and a couple of months into regular supported chart reviews. Since the chart reviews began, community providers have observed improvements in preventative care and management for Indigenous life givers. An evaluation participant shared that early identification of pregnant patients has enabled tests to be ordered near the beginning of pregnancy as needed, and enhanced the ability to initiate early conversations about mental, emotional, and spiritual health and wellness. And this was noted to be especially helpful for people who are pregnant for the first time. Providers also described the ability and expertise of the MABEL team, sharing education on changes to watch for in pregnancy and helping to identify risk factors that might indicate an obstetric concern or other concern that could become an emergency before it becomes an emergency. And improve continuity of care and strengthen relationships. The consistency of the two providers, myself and Amy, was identified as critical and important because it ensures familiarity with the patient's charts and continuity of care through the pregnancy and postpartum. And then the detailed discussion summaries and care plans that we send back to communities at the end of each session have been identified and have been saved into the patient's chart and have been identified as an essential tool in handover between nurses as they come and go from the communities. And the nurses in their handover notes have started referring to the chart review documents so that incoming nurses know what to look for. Core enablers, our relational approach, our experience in rural and remote settings, and our understanding, cultural humility and sensitivity, our ongoing work with that and practice to improve, and the continuity and reliability. And another quote, relationships and trust are really important. So for me, knowing the providers who are supporting and the experiences that they've had working in the far north and understanding the social challenges and geography of our communities is really, really important, because it allowed me to trust that when they were reviewing things, they wouldn't be making expectations that were unrealistic or actually harmful. We're almost finished. Looking ahead as we continue this work, we are sharing our key learnings and our core enablers to be able to spread it for other people to be able to step in and do this locally or with local communities to them, to continue building on recommendations to enhance the services. And we're exploring opportunities for new collaborations with communities, partners, and providers. So don't hesitate to reach out to us anytime. And our last quote, from an Indigenous lens, I think of the Mabel providers and the chart review service as the firekeeper. So the firekeeper in my home when I leave is my hubby, right? That's the person that maintains the continuity of the household. Those are the firekeepers of the continuity of care with the transient nurses staff coming in and out. They hold some type of balance, like roots for the program to run. So I wanted to say it that way because truly, immediately, I thought it's a firekeeper role. It's a really important role. Thank you.
Thank you. Wonderful and powerful presentation. And Emily, I really appreciate that. And with that, we could just jump into the Q&A. So we have the first question, Silviana asked, how is the Mabel in partnership with another virtual care pathway like Charlie being evaluated for its impact on health equity in maternal and newborn outcomes, and what strategies are considered to sustain these pathways? Thank you.
Silvana, thank you for that question. We have ongoing evaluation and several metrics that the programs gather in our data and feedback on an ongoing basis. I am not the best I'm not on that team, so I'm not the best person to specifically speak to it. We have produced, I think the RTVS 5-year report was released a couple of months ago. I'm not sure if it was public or just an internal report for healthcare partners and funders right now. I'm looking to Anne.
Yeah, I was going to say I'd be happy to share in the chat once we wrap up that 5-year report. And one thing I can share about the evaluation, particularly looking at health equity, is some of our work with the UBC Learning Health Systems team is looking at the impact of on patients, and particularly around patient transport and the costs of having to leave community and how that can be mitigated through virtual supports that meet patients where they're at. And so that is work that recently started this past year and is ongoing to kind of expand into what is the impact directly to patients.
Thanks, Anne. And to the second part of the question about what strategies are considered to sustain these pathways, it's likely known that we've had some reduction in service just in this last week and maybe for the next 6 months. We have so much support from patients, from communities, from health administrators, partners in all of our health authorities, advocating quite relentlessly right now and quite persistently and consistently to sustain and support the services. And we know we have many teams in the background working on it on a regular basis. It's everybody understands, I think, the critical nature of the services and the essential safety and support net that they provide for rural and remote communities, and is committed to seeing these services continue. Full stop. That's we're working around the clock right now.
Wonderful. Thank you so much for the great answer. I also have one question. So how do you think like co-learning approach changes relationship between, let's say, the outside professionals and the local ones, local healthcare team, let's say?
Yeah, thanks, Nazrin. I come back to trust and understanding. And networks. And so it builds those relationships of trust and understanding. And that I think of it, I think of it as a phone a friend. And that really showing up in the non-judgmental, open, curious, how can I help way, enables local providers to say, I have a question. Can I ask this question? And asking the questions becomes easier and easier as the relationships go stronger. And then continues to build the networks of people that are interconnected. And so we've seen one of our virtual MOAs who helps set up the calls each time, has with new nurses in community, takes calls from nurses all around BC, rural and remote BC, has come on, and the new nurses come on the line, seen that familiar face and said, oh, I know you. And immediately there's a warm handover that enhances trust and relationship. So it's continuing to build that interpersonal connection.
Thank you. Love that response and trust and, being ourselves. So it's really helpful. Thank you so much again, Anne and Lee. Great presentation, very powerful. So with that, I invite the next presenters, Vanessa Salmons and Maureen Haley, to please share your screens. And yes, please go ahead.
Hi, everyone. Just bear with me. How does that look? And can you hear me?
Yes.
Yes.
Pretty awesome.
Good.
Yes, and we can hear you.
Thanks, took me a minute. I thought
you.
I was off mute talking away for a minute. That happens every day. Good afternoon, everyone. Thank you very much for joining this presentation, this rapid fire presentation, to describe a quality improvement initiative to improve postpartum and newborn discharge communication in Northern BC. I just want to start by acknowledging with gratitude the many territories, First Nations territories, to which we are all situated within today across our northern region and province, and also the 11 Métis chartered communities. We are thankful for the continued opportunity to work together in partnership and uphold Indigenous rights to health and to optimize the health and well-being of the Indigenous people and communities we serve. So thank you for this opportunity to join you today.
Good morning, and just a quick introduction. I am Maureen Haley. I'm a manager of clinical operations here in Prince George, located at the health unit for community services. And Vanessa Salmons is our amazing executive lead of perinatal services network, Northern Health, and she is located in Quesnel. We really want to acknowledge some of the team members that helped us put the presentation together and were integral in this initiative. Carly Finney is the interim quality improvement lead for NI Rural Northern Health, and Randy Parsons is the regional nursing lead for maternal infant health and Northern Health, and of course our entire project team, which we'll highlight later. Thanks, Vanessa.
Great, thank you. Maureen and I actually met together earlier this week and had a photo together. So that was really nice for us to be able to touch base in person. So for the next few minutes, this is the outline of our discussion today, or our presentation. So we're going to share with you and define the problem that we've been having for decades for postpartum and newborn care transitions from acute care to community, and share the quality improvement approach and the technology solution that we came up with. I say a royal we, and we'll get into the team in a moment. We'll highlight the challenges and lessons learned in this project, and celebrate some successes and outline next steps in this project spread.
So the problem, which was pretty significant, seamless transitions in care from hospital to community are essential for postpartum parents and newborns. And in Northern Health, this includes notifying the primary care teams and the transferring the discharge paperwork from our maternity unit. So our fun picture here, which might not make sense to people, but we actually started off with having the teams from the health unit actually walk over physically to the hospital all times of the year in order to gain this paperwork. We finally came to a faxing solution, and then we had a Xerox DocuShare solution to try and get at least the information to the Northern Interior Region Health Service Delivery Area. However, one other issue is that Prince George was considered more of what I would call like a regional primary care team. And we received all the paperwork for all of the outlying communities in Prince George, which would slow down getting the information where it needed to be at the right time. What would happen quite often is that methods, when it would come through fax, it's very incomplete, it was illegible, and it really highlighted the need for a more reliable and standardized process to be able to follow up on timely care. So that's when we started talking about this quality improvement initiative to explore like a really sustainable digital solution to support family-centered care and to connect postpartum families to their primary care teams, ultimately within 24 to 48 hours, which is a Northern Health clinical practice standard and a provincial standard of care. Next, Vanessa.
Good, thank you, Maureen. So with our quality improvement support, we developed an aim statement to guide us in this work. And so by spring 2025, we wanted to implement a secure, efficient communication pathway between UHNBC in Prince George, the maternity unit in the hospital, to the Prince George primary care teams to ensure timely postpartum and newborn care follow-up. So this project we wanted to focus on in Prince George specifically. Prince George is our largest hospital and our highest tier of care hospital, with many folks coming across the region and in other rural NI communities to birth. And so we wanted to solve this problem in our largest center and community first, and particularly with the Prince George challenges that Maureen had mentioned. But the intention of this project, and we'll talk about it later, is with this solution to be spread and not to be a pilot project that dies. So we'll get into that in here in a moment. So the project team just really shows the collaboration that occurred through this project. So we had a multidisciplinary team supporting this work across operations in both acute care and community. So program leadership and management from UHNBC in maternity, and also Maureen's leadership and her team leads in Prince George community. We had strategic analytics, clinical informatics, which we'll see as it was instrumental in this project. We had evaluation supports, quality improvement, project management, and we had population public health through Randy Parsons' leadership as well, to help guide, that postpartum and newborn supports and transition in that space. We had privacy and information governance as a key partner here as well, leadership through the perinatal service network, reporting, and various IMIT components. So it really crossed a lot of areas in our organization, which was really great to see. Wanted to just demonstrate with this project the strategic alignment and governance for this. So it's well connected with the Northern Health Strategic Plan at the top and the organizational objective of coordinated and accessible services. We also have this connected to a specific initiative within the Coordinated and Accessible Services to Strengthen Care Models and Pathways Initiative, which the perinatal projects that we have outlined in our service plan are well defined within that. With our service plan, we have a 5-year service plan for the perinatal service network, and one of those recommendations is to improve patient access and transitions across all levels of perinatal services as close to home as safely possible. There's many transitions in perinatal care, and this is one of those transition points that have been a pain point over many, many years, being this discharge communication for the postpartum newborn dyad from a birthing site to community services. So that's really key there. We also applied several lenses to this project. So both a strategic lens through the service network and attachment to our goals and projects, and with the strategic plan, as I noted, but also quality improvement lens and how to solve a solution in a PDSA format. And it came quickly. We wanted to focus on a technology related solution. So the technology solution lens and how it could be adapted to other areas of care, a collaborative lens, which you could see from the project team, and also an accreditation lens. And you'll note that transitions in care is an ROP in our accreditation standards, and one of them specifically is around communication and promoting effective information transfer with clients and team members across the continuum of care. So this is a really strong way to report that out through our accreditation program as well. Off to you, Maureen.
So yeah, we're going to talk about our quality improvement approach. So process modeling was used to document the current state of the document transfer. And that's when we realized we really needed to pull together that interdisciplinary team that Vanessa highlighted on a previous screen. And then we ran into a couple of hiccups with technology and privacy feasibility. So we didn't engage our frontline and our patient engagement right away. So it was deferred from the initial phase coming later. So we started off with a proposed solution and had to work through our privacy impact assessment and really decided, because of the scope of this project, we needed to keep it small to ensure that we could get it right the first time, to really have spread, like Vanessa mentioned in an earlier slide. So we started off with testing, and it was a very manual process. So we did land on using a Microsoft Teams solution and started off with some folders that would allow us to communicate between Prince George and the hospital. And so through doing some of our PDSA, we're realizing it was creating a lot more time for our partners over at Acute to get the information to us. So we went back to the table with our IMIT group to find another solution. And it was the winning solution. We were very excited, and I'm excited for Vanessa to introduce it in the next slide.
Thanks, Maureen. So what was the penultimate solution? Well, it ended up being really quite simple, actually, and a solution or an app that I didn't know about previously in Northern Health called Microsoft Power Automate. So really, it was as simple as using the Xerox scanning function located on the maternity unit. And with the behind the scenes Power Automate solution, which the technology solution, this workflow adds the discharge information into MS Teams folders. So it's quite interesting. It's a behind the scenes automated workflow that we rely on the computer to follow a series of predetermined steps. So if then logic to allow this information to land in the appropriate Teams folders. So it's not artificial intelligence at all. It enables a secure, efficient transfer of discharge records. So we do have these technologies that enable so much potential for automation, but further supports are required in Northern Health to help facilitate this type of functionality across our system. So more on that. So a few learnings, I know we're probably getting close to time, but a few learnings just to touch was, we assumed early on in the project that through Microsoft 365 that a PIA had been done and it would cover off this project, but we were mistaken. The use of the file folders in MS Teams in this way needed a specific PIA, privacy impact assessment. So we're really thankful to our privacy team working with us and getting us to a stage of having this in place, and we can move forward with the project. Maureen mentioned the second was a manual process was initially started to actually get this information in the MS Teams folders as we envisioned, but it was a lot of work. So that was the first PDSA, and then our lovely informatics team, can't say more about how great they are, learned of this Power Automate workflow, and so that was enabled for this particular project. But more is needed to better support these automated processes across the organization. So that's the next learning there. Pass it to Maureen.
Yeah, and this is where we really started our evaluations and lessons learned. So we piloted for 4 months, and this is where we really got to speak to our frontline users and learn what the experience was for them. And so we did have a survey after we had implemented it, and it was so favorable. And it was favorable because of the ease of use for the Power Automate process. And so it really encouraged us to have belief in this system and that we're going to be able to spread it out throughout the other sites through Northern Health. And I think it was just so important to state that the frontline staff felt very listened to, that the manual system was not going to work for them. And so it goes to show that it's so important to listen to the people on the front line actually doing the work to determine what is going to be the best solution in this information and transitions in care.
Thank you. So next, what's happening next? So for fall winter 2025, our hope is to spread in one fell swoop through the Northern Interior HSDA to start. So we've engaged with GR Baker Hospital in Quesnel and St. John Hospital in Vanderhoof already with the leadership groups there. And I have actually had some early conversations with all the senior leadership teams and all the HSDAs, but starting with those 2 hospitals to add in as sending sites as the 2 other birthing sites in the Northern Interior, and I've had some early sharing and discussion with all the CSM team lead group in Northern Health around this project and future spread. So we are just working through the IMIT process for Power Automate and looking to process for just timelines on that as far as next steps. Also, sort of future state, we talked about the Northern Interior, so we'll kind of work through those Northern Interior sites. Again, PDSA, work throughout any kinks or resources that need updating. and then look to the other birthing sites as sending sites and all the community teams in Northern Health. And there's also opportunity with our First Nations communities as well to look at, again, better workflows and how to move documents and information. We actually have another project in our perinatal project cadre of things specifically with Hartley Bay and Gitga'at First Nation and with Prince Rupert and prenatal care and access with that. So this project does link really well with that one. Lots of interest, like things are bubbling through other service networks and teams about how this discharge information could work for other patient populations that are being discharged. So lots of buzz, but there is more consideration needed to support our IMIT teams and informatics with developing processes and resources to support this type of automation. We have the technology, but we need the supports to be able to move it forward and spread further.
Thank you, Vanessa. I think we're at time. So thank you so much, Vanessa and Maureen, for the wonderful presentation about incorporating digital health into the rural area. Is there any questions?
Ended just in time.
Yeah, perfect.
No questions allowed. Thank you. Please put it in the chat.
I had a question, but I think since we are at time, we will just move on to our next presenter. So with that, I would invite Bertha Chapoloko to please share your slides and start presenting. Thank you so much. Bertha, are you here? Just gonna check the participant.
Okay, are you able to get me?
Yes. Your background is really dark, but we could definitely hear you and see you.
All right. Okay. Thank you so much. We're having challenges with power. Yes. So I was just asking if at all you can help me out with the sharing of the
Yes, absolutely.
PowerPoint.
I can just share your slides.
Okay.
Yeah, totally.
Thank you so much. We really appreciate. Oh, thank you so much. So this time, I'm very happy to present my presentation, which is on pseudocyesis or false pregnancy. This condition is really something that has affected a lot of women, of which I decided to come up with my own theories and so forth. I even came up with my own book concerning this thing. So I decided to come up with a research proposal, of which I decided to come up with a research proposal. So I came up with just a summary of the research proposal from the many research proposal, which I'm about to share with you. So we'll just start with the introduction so that everyone will be able to understand what I'm trying to talk about. So I'm just excited to present the research proposal on pseudocyesis, which is all about assessing the experiences, practices, and outcomes of pseudocyesis by victims, witnesses, healthcare providers, traditional healers, and plague men in Zambia. It is also known as false pregnancy. So this condition where individuals believe they are pregnant with an actual pregnancy, presenting a fascinating intersection of psychology, biology, and medicine. So my research aims to explore the underlying causes and implications of pseudocyesis, contributing to better diagnosis and change of options. So according to my observation, women report prolonged gestational periods. E.g., others say maybe it could be, they might say that maybe it went up to 15 months, 16 months, 18 months, or even 22 months. following a pseudocyesis diagnosis, with some attributing eventual childbirth to spiritual or traditional healing intervention. Yet health care providers frequently disregard these accounts, attributing them to
Excuse
delusions
me,
rather than
Bertha.
exploring.
Bertha, sorry
Yes.
to disrupt, and my apologies. Would you please tell me next so I can move to the next slide on my end so people can
Okay.
see and follow?
Okay.
Thank you. So are you still are we good on the same, are we on the same page? You are frozen, Bertha. I don't hear Bertha anymore. I don't know if it's on my end, or everyone else cannot hear Bertha either.
No, I can't hear right now either.
Yeah, that's what I thought. We know that she's joining from outside the country, and we know that previously there were some technical issues on her end.
Oh.
Are you back? Okay, great. So yeah, if you please let me know so I can click and move on to the next slide, that would be great. Thank you.
All right. Okay. Thank you. So just kindly move to the next. To the next slide.
Yeah, I just clicked on next. You don't see it?
Oh no.
Okay.
It's showing the
But you
first.
can
It's showing the
continue.
first slide.
Okay, so let me go back to it.
Okay, you're still on the first slide. Kindly move on to the next.
Yeah, I'm gonna stop sharing and restart sharing again so I can see the slide.
All right.
You can please continue. I will just put it up right now.
All right. Okay. Thank you. Yes. So what I was saying was that many women report prolonged gestational period, e.g., 15, 16, 18, or even up to 22 months following a pseudocyesis diagnosis, with some attributing eventual childbirth to spiritual or traditional healing interventions. Yet healthcare providers frequently disregard these accounts, attributing them to delusions rather than exploring potential misdiagnosis or alternative etiology. May in fact involve overlooked medical or cultural or psychosocial factors. Kindly move for me to the next slide.
Absolutely.
So let us just try to look into the background or context of this issue concerning pseudocyesis. So this phenomenon has been documented for centuries, yet its underlying mechanisms remain poorly understood. The prevalence of pseudocyesis across populations, with higher reported cases in cultures where motherhood is strongly tied to social status. However, comprehensive biological and psychological studies remain limited. Global reported cases remain sporadic, but prevalence is thought to be higher in settings where motherhood is heavily emphasized and infertility carries significant social stigma. In Africa, pseudocyesis is believed to be more prevalent due to social culture and infertility. However, limited mental health infrastructure and cultural attributions causes contribute to underdiagnosis. In Zambia, where fertility rates are high and societal expectations of motherhood are deep-entrenched, pseudocyesis may be common than documented. The condition is often misunderstood, with symptoms sometimes attributed to witchcraft or spiritual affliction rather than psychotic distress. So the traditional healers often serve as first-line consultants for such cases, whereby they even delay the biomedical intervention. So the current treatment approaches for pseudocyesis are inconsistent, whereby they range from psychotherapy to hormonal intervention with varying success rates. Given the profound psychological distress and societal stigma associated with the condition, further research is needed to elucidate its etiology and optimize therapeutic strategies. So this study aims to systematically review existing literature on pseudocyesis, analyze its neurological and psychological correlates, and evaluate evidence-based modalities like to improve in clinical management. So given these gaps, this study seeks to investigate the prevalence, social cultural determinants, and health-seeking behaviors associated with pseudocyesis in Zambia by integrating biomedical and psychosocial. The findings could inform interventions to improve diagnosis, mental health support, and community awareness. So to dive into the research proposal, what's my main objective or general objective? It is to compare pseudocyesis across cultures, analyzing social cultural influences on its presentation and interpretation in Zambia. Then, what's the research question of my proposal? Is one, why is there a claim of pseudocyesis producing babies? Then, I come up with two hypotheses, which is a hypothesis and the alternative hypothesis. The now hypothesis being there is no significant association to pseudocyesis and underlying factors. While my alternative hypothesis is there is significant association between pseudocyesis and the underlying biological factors. Let's start with methodology. This study utilizes the research design. This is appropriate for assessing the knowledge, attitude, and practices. Of healers, healthcare, and plague on pseudocyesis at a single point in time. This particularly for health-related surveys that to evaluate public awareness, perceptions, and so then, at a later stage, quantitative analysis of clinical data will be formed as a separate project. Then I also shared my project plan and timeline, the milestones. So this literature review, there will be literature review, participant recruitment, data collection and analysis, and drafting the final report. The new timeline, the project will be expected to last for 3 years with key milestones achieved at 10 months, 11 months, 16 months, and 19 months. Then in conclusion, what I'm saying is that this research aims to deepen our understanding of pseudocyesis, ultimately improving diagnosis and treatment of those. I believe my findings will contribute significantly to the field and offer the opportunity to conduct this important way. Then I just also shared my study plan there and my study budgets. That's the end of the summary of my main research proposal, which I did not share issues of time and network issues. Yes, I think I'm done. But so people are free to ask.
Thank you so much, Bertha. I think you're breaking out. I don't. So yeah, I don't know if other people can hear you or not. I'm just gonna go check the chat. Okay. Yeah, we can't see the slide progressing. So I don't know what time that was, but I was clicking at some point on the slides. So Vanessa, I hope that you saw some slides are moving forward.
Yes, it did get corrected. Thanks, Nazrin.
Okay. Yeah. Perfect. Yeah. So yeah, is everyone okay? Is everyone hearing Bertha good? Because on my end, I heard her a little choppy. Yeah, there's always some issues when I mean, we are trying to join from outside the country. I think hopefully we haven't lost Bertha yet, but I don't see her anymore. I don't think that I see Bertha. So if someone could please like confirm that they don't see Bertha either, then
It looks like Bertha left.
okay.
Nazareth.
Okay, so it might be on her end due to technical issues that we anticipated that might happen. So at least I'm glad that she could cover a good majority of her talk today. So thank you so much. And I think we have a couple of minutes, so if you wanna like.
Nazrin, you're on mute.
Yeah, sorry. So yes, so if anyone has questions, please go ahead. If not, I mean, I'm going to go ahead and contact Bertha and let her know that we got through her most of the good chunk of her presentation. I had a question for Vanessa and Maureen now that they have a couple of more minutes. So it's really great that your team is trying to integrate digital technology within the healthcare system, which I believe this is really important. I lived in Whitehorse for a little bit, and then I know how difficult it is to get like healthcare system help in Whitehorse, and Prince George is the same as in the northern context. So I was wondering, introducing this telehealth, let's say, or digital context to the healthcare system, how do we do that, or what are the lessons learned that actually make us not to overwhelm the patients and the healthcare system providers?
Yeah, thanks so much. I think it links into Lee's presentation as well, as far as integrating, in-person connections with virtual. And I think this project specifically, really didn't have the patient in the middle of it. It's how to transfer information, documentation information that occurred in acute care, so that community services could follow up appropriately in a timely manner. So, the patient perspective is that they're receiving their care within that 24 to 48-hour standard on the community side. And we haven't been able to solve the interoperability between EMRs. And I know there's a couple comments in the chat about Cerner and PowerChart. And unfortunately, there's no way to send information from Cerner directly to the EMRs in either community services or primary care. So it is a workaround, but it is a solution that has worked. And unfortunately, even with in-care and safer care that's coming with Cerner application for inpatient documentation, it still will be a hybrid approach for maternity documentation because of the financial limitations on that purchase. So yeah, this is what's worked and can work in all of our birthing sites in the meantime. So hopefully it's a solution that offers improved patient care and connection early on for that important early postpartum newborn contact.
Absolutely, thank you. That's a great response. Thank you so much, Vanessa. So with that, if we don't have any more questions, we can end the session. And if there's any more questions, and if people want to participate and want to talk one to one another, on Fitloop we have the chat option that we could ask questions and get to know one another a lot better. So I invite everyone to check that out. And thank you so much again for everyone joining this session. It was wonderful, and for me personally, I learned a great deal out of this conversation. So thank you so much, and have a beautiful rest of your day. Hopefully we see each other in other sessions. Thank you. Take care. Bye.
Thank you.